All right, chapter 36. These are all blood vessel problems. Let's begin with hypertension. So there are two classifications of hypertension. We have primary and secondary. Either way, why we distinguish is primary are usually caused by non-modifiable risk factors, whereas secondary, by the term itself, it occurs secondary or as a consequence of another problem. So how does hypertension damage organs? Okay, so they can cause stroke and MI, kidney failure, namely because imagine if the pressure in your bloodstream is constantly high, what will it do to the delicate blood vessels? Because, you know, arteries become arterioles and then finally they become capillaries. So if these vessels are constantly exposed to these high pressures every single day, what will eventually happen to the organs that they're supplying?
Failure.
All right. Not to mention also that high blood pressure puts extreme stress on the heart. The heart now has to work double or if not triple just to circulate blood because of all the resistance placed on the heart. All right, so it's not just the resulting pressure, but also the strain it causes on the heart. So that's how it causes myocardial infarction. As far as the stroke, this will particularly be hemorrhagic stroke, although hypertension is also a risk factor for ischemic stroke, but most likely it will be hemorrhagic in nature, meaning you rupture a vessel in your brain. And then finally, kidney failure. Remember, the functional unit of the kidneys are microscopic nephrons, and those nephrons also have microscopic blood vessels. So therefore, constantly exposing them to high blood pressure, of course, will damage the nephrons, and then that's how you lose the kidneys. However, one good news is hypertension is no longer the #1 cause of people going into dialysis. It is now diabetes. So diabetes is now #1. So blood pressure, hypertension is defined as a blood pressure of 140/90. So that means pre-hypertension starts at 120/80 up to 139/89 technically. And then anything below 120 and above 90 is, of course, our normal blood pressure. So you can read these, how these mechanisms influence blood pressure. I'll stay with preload and afterload. So we discussed the renin-angiotensin system, the sympathetic nervous system responses in chapter 11 extensively. So these, of course, affect preload and afterload. What is preload again? Miss Perez? What about Miss Selena Perez?
Yes, Professor.
So what is preload again?
Who are you talking to? Preload is, hold on.
What is preload referring to?
Blood volume.
Very good. What about afterload? What is it referring to?
Resistance, stretch, blood vessels.
Blood vessels and also the heart valves, right? So don't forget these again. These are terms we will be using in all succeeding chapters here. So beginning with chapter 35, 36, and so on. All right, so we have primary and secondary, as already mentioned. Primary is also called essential hypertension. Malignant hypertension is different. So this one is related to, this is not also hypertensive crisis. So crisis is a complication of uncontrolled hypertension. Malignant hypertension is a type of hypertension that is progressive. Okay, and these are the symptoms, because usually patients with hypertension usually have no symptoms. They only develop symptoms if the blood pressure is extremely high. So these are the causes, table 36-1, essential, as I mentioned, mostly non-modifiable, but the others obviously can be modified or controlled. Secondary, these are, again, conditions that lead to hypertension. Kidneys control fluid and electrolytes, so therefore if they fail, they cannot control fluid volume anymore, so preload increases, you have hypertension. Primary aldosteronism, this is a condition wherein you have a tumor on the adrenal medulla, causing an increased production of aldosterone, and of course aldosterone reabsorbs water and sodium, so that increases preload, leading to hypertension. Pheochromocytoma is a catecholamine producing tumor also on the adrenal, but this one's on the adrenal cortex. So this one will, this tumor will cause an increased production and release of your epinephrine and norepinephrine, leading to increased afterload. Cushing's disease, this is a condition of the adrenal glands again, resulting in high sugar and salt hormones. So you have a high cortisol, high aldosterone level. So that will, both of those will of course increase preload, leading to hypertension. Coarctation of the aorta. Have you done cardiac yet in peds?
No, next week we're gonna do it.
Okay, so this is a congenital defect wherein the aorta is narrowed at one point. This is usually around the arc. The aortic arc is narrowed, or there is a stenosis or a stricture there, leading to increased afterload, leading to hypertension. Brain tumors. How does brain tumors cause hypertension? Well, this has something to do with the hypothalamus, which of course increases ADH. Another thing is the brain has something we call autoregulation, meaning it's a protective response to brain injury. Brain tumor causes brain injury because it's a space-occupying tumor. So therefore, if there is a threat to the blood flow to the brain, the natural response of the brain is to increase blood pressure. The purpose of that response is to maintain cerebral blood flow. You learn more about that in chapter 45, 2 semesters from now. Encephalitis does the same thing, because this one will lead to increased intracranial pressure. Again, stimulates the autoregulation of increasing blood pressure. Pregnancy, because you have increased preload here, now you have double your, or almost double your blood volume, because now you're feeding a growing fetus as well as a growing placenta. So that will double your blood volume, increasing preload. Drugs, this one will cause fluid retention, increasing preload. Glucocorticoids, the same, increased preload. Mineralocorticoids, it's referring to hydrocortisone, which has the same effect as aldosterone, again, increasing preload. And then sympathomimetics, this one will cause vasoconstriction. So these are drugs that mimic the effects of epinephrine, namely Sudafed, for instance, or any other drug that contains phenylephrine, because these are vasoconstrictors which increase afterload. Same thing here. When we talk about essential, these again either cause increased preload or increased afterload. Hypolipidemia will narrow your arteries and veins, causing increased afterload. Same thing for smoking. Smoking will cause plaque deposits, narrowing, and it's also a vasoconstrictor, increases afterload. So we can go on and on here. All of them cause either increased preload and or increased afterload. These three paragraphs here are the explanation of what I just said. So please read that on your own. Prevention. The guide here is to do the DASH diet. DASH stands for Dietary Approaches to Stop Hypertension. On the exam, you won't see vegetables, fruits, whole grains. You will see actual vegetables, actual fruits, actual whole grain products. Low-fat dairy products or seafood are good. Limit your carbs and red meats. Remember, red meats also refers to red meats. Liver is also red meat, so don't just when you think about red meats. Control sodium, 2.4 grams. That's not, I mean, we talked about sodium already in chapter 35. Increased activity. Again, the recommendation here is walking or swimming. As far as smoking, the rule is to stop smoking. Okay, there's no such thing as to cut down on smoking. Smoking has no benefits whatsoever. So it's really stop smoking. However, when it comes to alcohol, alcohol isn't all bad. So it's only here no excessive alcohol. So moderate alcohol intake is okay. All right. So if you look at again, this is the DASH diet. It didn't say you need alcohol. It just says lower or keep a moderate intake of alcohol. Signs and symptoms. Except there are normally no symptoms of hypertension, which probably is what's causing it to be really deadly, because the patient doesn't know they have hypertension because there are no symptoms. When these symptoms appear, it's already a result of a really high blood pressure. That's why you probably heard of the expression that hypertension is a silent killer. Now, the appropriate blood pressure measurements necessary in order to make a diagnosis, because there are no blood tests to be done. Our only diagnostic tool here is the blood pressure machine. So we use the sphygmomanometer and the blood pressure cuff. And so because of this, we need to make sure our measuring tools are appropriate, the right size for the right size patient. So please review, and it's on your blueprint for exam 2. Please review your Potter and Perry book about the size, the appropriate size for your blood pressure cuff. Right, so how much of the arm must it cover? What is the circumference, okay, the ratio? How much of your arm must be covered? What are the effects if your blood pressure cuff is too small or too big on the blood pressure readings? All right, so those are all these questions on your exam. You know about orthostatic hypotension, right? It should have been discussed in fundamentals. So this is a difference of at least 20 millimeters of mercury between lying and sitting. So in order for it to be positive, there has to be a 20 millimeter difference. Now, the other exams here are not symptoms of hypertension. They are rather evidence of the damage of hypertension to other organs. Number 1, the eyes. The eyes also, just like the kidneys, have fragile, tiny blood vessels. they can be damaged by hypertension as well. Or you can see possible causes. So this will be, again, they're not used to diagnose hypertension. They are used rather to see either the cause, meaning to see if it's secondary hypertension versus essential hypertension. And again, to see whether or not the patient is already having multi-organ damage as a result of uncontrolled hypertension. Please read the psychosocials on your own. Okay? If you haven't noticed already, between chapters, from one chapter to another, psychosocial assessments are pretty much the same. Every illness will result in some form of relationship problems, some anxiety, some if it results in a change in the patient's independence, for instance, just like in heart failure. So of course that will cause not only self-esteem problems, but also performance-wise, meaning let's say you're the head of the family and then all of a sudden now you have heart failure, you can't do what you're used to be doing. So your role changes also in the family. As already mentioned, there are no lab tests to diagnose hypertension. These tests mentioned here are, again, used to either see the cause if the patient has secondary hypertension, or again, the damage done by hypertension to target organs. Prevention is first. So you saw chart 36 table 36-1 listing causes and risk factors for primary and secondary hypertension. So you address those. If it's obesity, then lose weight. If it's the diet, then restrict sodium. Add here again your DASH diet. Right. So if you look at these lifestyle changes here, these are the same things already mentioned under DASH. Here's the alcohol use. Again, there's no need to eliminate it. Smoking, though, you have to stop. There's no such thing as use smoke moderately or sparingly. Okay, so it's only stop smoking. Here are complementary. Q10 has been proven and also approved by FDA to have cardiac benefits. It's good for the heart, also good for your blood pressure. So is garlic. Good thing now we have FDA approved sources of garlic. Used to be we really didn't know how much garlic and how much it affects blood pressure. So now they have amounts now there, so they're more precise. So and the FDA did approve their use.
I have a question.
Go ahead.
If someone's already on like medication for high blood pressure, can they still take like the garlic or the coenzyme 10?
With that, always in consultation with their physician. Because let's say I've had patients before wherein they take over-the-counter herbals without their doctor's approval, and it may dangerously drop their blood pressure. And sometimes they have interactions also. So again, I would advise them to consult their physicians before taking any of these over-the-counter products.
Okay.
All right, drug therapy is easy because we already did this in chapter 35. If you look at these, we have ACE inhibitors, beta blockers, calcium channel blockers, diuretics, and of course the DASH diet. Okay, so as far as drugs go, we have chart 36-1, and it's a drug chart. So the testable part here is always the nursing implications. I'll just go through these real quick. I won't repeat it again because we already did this in chapter 35. So you'll notice that these drugs either lower preload or lower afterload. Diuretics will lower what? Preload or
Preload.
afterload?
Preload.
Right.
Preload.
Very good. Remember that we have three types. We have potassium sparing, we have loop, and thiazide diuretics. Please look at specifically the teaching, what you teach the patient, and what's also the common side effects. They go together. Look here for loop and thiazide, for instance. Later, when you go to chapter, I think gout is chapter 19. Yeah, I think it's chapter 19. Thiazide diuretics, along with aspirin, have been linked with gout because they cause uric acid retention. So this is your warning here. They can be used for people with gout. And here's one with question on diabetics. We will start diabetes next week. Beta blockers, they all end in olols. Again, these drugs cause hypertension. All of them, of course, have cause hypotension because they're antihypertensive. However, beta blockers and their cousin, which are calcium channel blockers, affect heart rate. They've been known to cause sexual dysfunction, so please make sure which ones do, because this is a common cause of non-compliance. Male patients, even female patients, report sexual dysfunction. No need to, the important thing is to reassure the patients that there are alternatives, meaning instead of stopping the drug on their own, it's important for them to know that there are options that, okay, this doesn't work for you because it causes sexual dysfunction. No problem, we'll try something else. And one funny thing is, or strange thing rather, is one beta blocker may have sexual dysfunction while another will not. So it's really depending on how the patient tolerates it. So the patient and the doctor work together to see what works best for the patient. Here are calcium channel blockers. Now it's important to note that there are DHP calcium channel blockers and there are non-DHP. Now the non-DHPs are ending in dipines. Amlodipine, nicardipine. Okay, so if it ends in dipine, it does not affect the heart. It only affects the blood vessels, meaning the only calcium channels they affect are on the peripheral blood vessels. They do not affect coronary artery vessels. Is that clear? So for later when we get to chapter 34 and chapter 38, verapamil and diltiazem are not really used, are the only ones used for dysrhythmias because these are the ones that affect the coronary, it affects all vessels, but no, not the coronary. I'm referring to the myocardium, sorry. So remember, the myocardium are muscles. There are cardiac muscles. So the verapamil and diltiazem are DHP calcium channel blockers, meaning they affect the contractility of the heart itself, whereas the dipines only affect blood vessels, including the coronary arteries. And here are your teachings. So this one, calcium channel blockers interact with grapefruit, which can enhance the effect of the drugs. So very dangerous. They should know to avoid grapefruit and grapefruit juice. We already discussed ACE inhibitors back in chapter 35. So you know about the nagging cough. Again, the important thing here is they report the nagging cough because they don't have to suffer that. We can change the drug to ARBs. So these are better tolerated, but remember that both affect the renin-angiotensin system, so therefore they both will cause hyperkalemia. I'm not testing these. These are I have no questions on these. I don't think we need to memorize these. The explanations are here on the next paragraphs. Please take note that as far as hypokalemia goes, there's a difference between loop and thiazide diuretics. One thing here is the hypokalemic effect of thiazide diuretics is self-limiting, meaning they cause hypokalemia only to a certain extent, unlike loop diuretics wherein there's no limit, meaning because of the action of loop diuretics, they naturally promote potassium excretion. That's just how the drug works. Whereas in the case of thiazide diuretics, they work differently, meaning although they promote potassium bicarbonate and magnesium excretion, they only do so up to a certain extent, right? So time will come that they will no longer be able to excrete potassium, meaning only people taking loops are usually the ones that the doctors prescribe potassium supplements for. If they're on thiazide, usually the doctor doesn't worry about giving potassium supplements for that reason. So here's a warning again on sexual dysfunction. Please read that on your own and which drug is affected. So this was referring to thiazides particularly. And here's another for loops. And remember, potassium sparing, these are dangerous, okay? Because it's not like they don't have the effects of loop and thiazide. Potassium sparing diuretics literally prevents the natural elimination of potassium, meaning you and me, we normally excrete potassium because that's what our kidneys do. But when you're taking these drugs, it stops the kidneys from doing that. So this can dangerously conserve potassium, causing hyperkalemia. Here's another drug alert. Okay, so if you stay, no, I shouldn't say that. Never mind. So please read the other details here because I do remember grabbing questions on the paragraphs as well. So not only on the chart 36-1. They have, if you haven't talked about these in pharmacology yet, they have same sounding endings. So these inhibitors all end in prils, for instance, right? So they're not very hard to remember. So this next exam, exam 2, will be more like a pharmacology exam because there's not much we can do with cardiac and hypertension. We have to use drugs. And your ARBs, of course, end in R10s. They have candesartan, valsartan, losartans, and you know about the odols. All right, so let's talk about complications. So there's something called hypertensive crisis. So this is a condition, blood pressure of greater than 180/120. This one, of course, will cause organ damage. So this will kill your kidneys, kill your brain. It's dangerous. So during this crisis, the patient will not receive PO medications anymore because they won't work as fast as we want them to. So all drugs here will be given IV. So the most commonly used drugs. So this will also include a patient in stroke, because remember, if you remember what I mentioned earlier, if a patient has any brain injury, so either traumatic brain injury, stroke, brain tumor, or encephalitis, for instance, the blood pressure automatically rises in response to these conditions. Again, the purpose of the brain is to preserve blood flow to the brain tissue. Now, the drugs used to control those blood pressures in those conditions that I mentioned, in brain tumors, stroke, traumatic brain injury, encephalitis, are either labetalol or nicardipine. Both given IV are very effective to drop blood pressure. So see how how fast they do that. So this will do so quickly, right? So they're very effective, and most of the time, these patients in those conditions I mentioned, usually they may be unconscious already. So making PO drugs even more ineffective because they can't swallow. Okay, they're already unconscious. Here is your best practice, because hypertensive crisis is a life-threatening condition. You'll see these similar, although not technically called hypertensive crisis, there are hypertensive conditions which you'll talk about next semester and also in your 5th semester. But something in common you'll see are the signs and symptoms and the interventions. So regardless of the cause of the hypertension or the severe hypertension, the signs and symptoms and the interventions are most likely the same, regardless of the cause. So I said earlier, hypertension has no symptoms, right? Unless it's really severe. So when this one obviously is severe, so the patient will have these symptoms now. So those are, one thing not mentioned here is nuchal pain, meaning, pain in the back of the neck. And these are your interventions. The first intervention is always to put the patient in a sitting position. So this position drops the blood pressure. So therefore, when you have a patient in shock, do you put them up in a semi-Fowler's position?
No.
No, that's a very bad idea. Instead, you'll do a modified Trendelenburg instead. So you put the patient's head flat, or maybe 10 degrees, if any, and then you raise the legs instead. All right, we call that modified Trendelenburg. This one is for hypertension. So you'll see this in hypertensive crisis. And again, later next semester, you'll talk about a complication resulting from spinal cord injury. That one will result in severe hypertension as well. You'll see exactly the same interventions. Okay, number one is always place the patient in a sitting position. This position starts dropping it. I'm not saying that's enough, but this is your first, because you're not likely to carry nicardipine or labetalol in your pocket, right? So you put them in a sitting position, give oxygen. Now, be careful about this third intervention, because this is not giving saline a lot. All right, this is only slow, meaning maybe 30 ml per hour, maximum maybe 50 ml per hour, because you know the effect already. If you give too much fluid, what will happen to preload?
Increases.
All right, so that's not a good idea. So the purpose of giving fluids here is to make sure you have an IV line. And the only way you maintain a IV line patent is to have something running through it. You need a dependable IV line here, because remember, all your drugs are IV. If you don't have an IV site, you can't save your patient's life. Is that clear? So this, again, the purpose of running saline is to keep the vein open. You have a reliable IV access for your emergency medications. So here's this is labetalol, and this is, of course, your calcium channel blocker. And then you monitor blood pressure, and then watch for the complications. I mentioned earlier, this will cause a heart attack or even stroke. And watch your kidneys also, because the kidneys usually will suffer. So watch your BUN creatinine and your urine output as well. And for discharge, okay. One challenge in diagnosis is, remember, we have no diagnostic test, right? There's no blood test, there's no scan that will diagnose blood pressure. So the only way is to measure the blood pressure, which is something I forgot. Okay, 728. Let me go back to diagnosis. Okay, so the diagnosis of hypertension is done by obtaining the pressure in both arms, and 2 or more readings must be taken at each visit. Now, these visits must be separate, meaning you can't take the 2 or more readings in one visit. Is that clear?
Professor, can you repeat that one more time? You were cutting out a little bit.
All right. So again, there's no blood test or scan in order to diagnose hypertension, correct? So the only way is to obtain, literally obtain blood pressure readings in both arms. We need 2 or more readings at each visit. So it must be separate visits. You can't take 2 or more readings only in one visit. So these readings must be done at different visits.
Okay, thank you.
Now, because of white coat syndrome, have you heard of the term?
Yeah.
Yeah. Yeah.
Right, so our blood pressure, some people have a high blood pressure when they're in a doctor's office, right? So we call that white coat syndrome, meaning if they see somebody wearing a lab coat, a white lab coat, so their blood pressure starts going up. Now, to eliminate that factor, so the patient will be sent home with an ambulatory blood pressure monitoring device. They'll be wearing this at home in their own nice environment. They're relaxed, no one goes around, and this one will continuously monitor their blood sugar, their blood pressure every hour. And the readings are either written down manually, or some of these can remotely send the information, meaning they have digital, they connect with Wi-Fi and then will transmit the readings remotely to the doctor's office. So therefore, it does that constantly what they're doing at home, so you have a more reliable reading rather than taking it at the doctor's office, which can be influenced by white coat syndrome. And that's it for hypertension. Any question? All right, let's proceed with arteriosclerosis and atherosclerosis. What's the difference between the two? The answer is right here. So atherosclerosis is a type of arteriosclerosis. Thickening or hardening here in atherosclerosis is caused by a plaque deposit. Now, take note that the plaque is, you know the anatomy of the vessel, right? An artery has 3 walls. So we have the outer wall, which is externa, and then we have the media, tunica media, and then we have the tunica intima. So we have 3 walls. So the inner wall is where your blood is flowing through. The plaque is formed between the media and the intima. So it's not within, it's not on top of the intima layer. If you can picture that. All right, so this is your artery. So we have, this one will be the intima, the media, and that is external. The plaque is here So if I draw a plaque, it will be here. This will be your plaque. So it's not on top. So this one here is still your intima layer, and this is now your media. So it's growing in there. So this plaque can be caused by drive-through, nursing, nursing exams. What else about nursing? So nursing is a atherosclerotic risk factor, right? So stress is number one. We develop plaque deposits in one or more arteries. Now, the problem here is it really will depend on what artery is this. If we're talking about a coronary artery, then you have CAD. Patient, now this is now chapter 38. So patient has angina, has an MI, or STEMI, non-STEMI. If this artery is a cerebral artery, then we have TIA or stroke, or also called CVA. If this is a peripheral artery, it could be a iliac, femoral, popliteal artery. Now this will be called claudication. So it really depends on where did this atherosclerotic plaque grow, which artery is it affecting. So in the case of coronary artery, so imagine the plaque. If it's like this, it'll probably be no problem. But if this plaque grows, affecting now 50% or more of the lumen of the artery, the size of the artery, of course, narrows. So during episodes of increased oxygen demand, so you're mowing the lawn, you are running a marathon, you are studying for an exam, whatever other activity you're using, this look like a yin yang, right? Anyway, this is a plaque, okay? Of course, if the oxygen demand increases, so let's say you're exerting whatever you're doing, can the artery supply the needed increased oxygen demand?
No.
No. So in the coronary artery, if this occurs here, you'll have chest pain. If it occurs in a cerebral artery, then you'll have TIA or a stroke. If it's a peripheral artery, then you'll have pain in the legs. Claudication is pain in the legs. So really, it's the same thing. It's just a matter of which artery is this happening at. Are you with me?
Yes.
You understand, right? The concept. So when we go to chapter 38, chapter 45, and this one is in 36, it's really the same concept. So we have an atherosclerosis which caused the whole thing, and then the symptoms will be depending on which artery did this occur in. Because it's the same atherosclerosis, arteriosclerosis, factors are also the same. So what are these factors that cause these? So this is your normal artery. This one's the start, and then now this is the worst. So see where it forms, not really on top of the intima. This is here, this is the intima, and that's where your plaque occurs. Now this weakens the vessel. Look at this is the normal artery. So blood flows there, even if you have high pressure, you're fine. However, this one will increase after, right? So this narrows the artery. Plus, it weakens the wall. So what will happen also to the intima, the more it is exposed to high blood pressure? This will cause the plaque to rupture. So once you have a ruptured plaque here, then platelets tend to stick there. Now you have a clot, and you could have a stroke if this is a cerebral artery. It could be an MI if this is a coronary artery. Or it could be acute arterial ischemia if it is in a peripheral artery. Right? So it's the same idea, same concept. Let's go now to our risk factors.
In the last one, I'm sorry, in the last one, would they, that's when they need a bypass, right?
Depends on how many vessels we're talking about. If it's only 1 or 2, they can still stent this. But if it's a 3-vessel disease, then it's not worth it. So they'll do a bypass, yes.
Okay, thank you.
All right. So the risk factors, so they share the same thing. So a stroke, a heart attack, a PAD patient, hypertension, share the same risk factors. So they're all caused by, the diabetes will cause that. Diabetes, of course, your excess sugar will be turned into fat, and that fat is not only deposited in your belly, but also in your blood vessels. Smoking, eating habits, of course, this will be high fat, high salt diet, and less exercise. So they all contribute to plaque formation. I already described the rupture. So this will what will cause a stroke, a heart attack, if the plaque ruptures. So remember, the plaque weakens the intima, and that means if you subject this to high blood pressure, which it will, because again, you're increasing the afterload here by narrowing the artery. So once blood pressure is so high, it will eventually weaken and rupture the intima. And then once you have rupture, the illustration is in chapter 38. You'll have a better picture there. So once it ruptures, then you'll have platelets automatically sticking to that area. And then once one platelet is stuck, another will stick, and another, and another. And then before you know it, you have a big clot, which will now suddenly block the entire vessel, causing an MI, a stroke. All right, please look at the numbers for your lipids. There should be a table, but it doesn't have numbers, so forget about it. Here are your risk factors, 36-4. HDL is your good cholesterol. LDL is your bad cholesterol. So it needs to be the opposite. You need your HDL high, you need your LDL low. If it's the other way around, then you have atherosclerosis. That's fat. It comes in your family. You're diabetic. You're obese. You don't move much. You smoke. You're a nursing student. You're African American or Hispanic, or you just got old. These are all your risk factors. All right, let's go to PAD. PAD is next. Let's do interventions first. So regardless of the problem that you have, whether it's coronary artery disease, peripheral artery disease, cerebrovascular disease, because you have the same risk factors, the same cause, which is atherosclerosis or arteriosclerosis, interventions will be the same. So you know the risk factors, so you control table 36-4, you eliminate these or control them. And in the case of diabetes, then you stop smoking, increase activity, then those are your interventions, your modifying risk factors. And that will include also for nutrition, that's the DASH diet. Here, DASH diet again, they mentioned this again, so it's really the same as in earlier under hypertension. And we know to increase activity, drug therapy. So the most effective here are statins. I know you see commercials on TV about CoQ10 when you're on statins. Again, consult your doctor because Of course, the manufacturer of CoQ10 will tell you that, there's evidence that, it's good for the heart. It augments, or it's an adjuvant to statins. But there is really no evidence, but it depends on what you believe. So consult your doctor though before you start those supplements. There are non-statin drugs like ezetimibe is a non-statin. So is niacin, which is vitamin B, and we also have the fiber one, gemfibrocil. What's the brand name? I forgot the brand name. Lopid. Okay, Lopid gemfibrocil. That's a non-statin also, which is also used for cholesterol. However, the best evidence still is in statins. So the statin drugs are the best at cardioprotection, meaning they have the best cardiac benefit, okay, among lipid-lowering agents. However, they do have serious complications, namely liver failure, as well as damage to muscle. What do you call that? Not rhabdo, but anyway, we'll see it soon. So here's your prevention, primary and secondary prevention to control atherosclerosis. But again, no matter what you do, you probably will end up, because it took years of habit and lifestyle, right? Before you got to where you are, meaning your diabetes didn't get worse overnight, meaning this took years to develop as well as to control. And you never get younger, we only get older. So what I mean is the realistic outcome would be the patient will be on statins. Right? So that's especially here in North America, wherein everything's automated. We don't move much because everything is easy. I'm not saying that's bad, but so here are your teachings for statins. So this will, because it will harm the liver as well. So these are your warnings. Here it is. It will cause these symptoms here: muscle pain. They have unpleasant side effects like flatulence, diarrhea, constipation, and avoid grapefruit with them. Okay, and here are the non-statin drugs. They have their own side effects as well. As far as aspirin, pravastatin, aspirin now is added to if the patient has a higher risk now for cardiovascular disease resulting from atherosclerosis. Remember the plaque I mentioned earlier? So once the plaque ruptures, blood clot will form, right? So that's where your aspirin comes in. It will, even if you have a plaque rupture, you have aspirin on board, so that will prevent, at least, decrease the likelihood of clot or platelet aggregation, which will form a clot. Here's niacin, which is nicotinic acid. All right, so those are our therapy for arteriosclerosis. Any question? All right, let me finish with peripheral artery disease, and then that's it for today. PAD, this is the same atherosclerosis which obviously form in a peripheral artery. The most common arteries are the following. These are the ones affected. All that are listed here are the most common sites. So it begins from the abdominal aorta all the way down to your dorsalis pedis artery. Now, remember that this is a circulation problem. The plaque here, the narrowing of the arteries, occurs in a peripheral artery, usually in the lower part of the body. Very seldom do they affect the arms. It's only the legs usually. There are 3 stages. Chart 36-3, remember heart failure classification? I also recommend only memorizing stage 2 and 3, just like I asked you to only memorize class 2 and class 3 in heart failure, New York Heart Association classification of heart failure. So because look at stage 1, there's no symptoms, right? So if anything, you have decreased pedal pulses, that's it. Okay, so patient is asymptomatic, so no need, but we know the patient has atherosclerosis and therefore has PAD. Stage 2 is when the symptoms begin. So this is where, this is called claudication. When the patient has muscle pain, cramping, and burning with exercise. This is called intermittent claudication, because when they stop walking, they rest, they take a seat, the pain goes away. However, when they start walking again, they start exerting again, it comes back again. It is reproducible. So exactly the same thing happens. So just like this would be the same pattern as in chapter 38, when you talk about chronic stable angina, it's the same thing. The pain comes on when they exercise, so when they're moving. So here, instead of the leg having the pain, in chronic stable angina, it's the heart that has, there's chest pain there when they move. But just like here in stage 2, the claudication, which is the equivalent of chest pain if this was in a coronary artery, the symptoms are reproducible. So the next time the patient exerts, again, exercises, or shovels snow, for instance, whatever, the chest pain comes back, and when they stop the activity, it goes away. So reproducible. Stage 3 is not worse because even at rest, the pain is there. So it's not claudication anymore. Claudication is only pain on exertion. Here, the pain is there even at rest. So same thing again, when we get to chapter 38, the chronic stable angina can become unstable. In unstable angina, the pain is the chest pain is also there at rest. So the patient here resting, there's pain in the legs. Okay, for no aggravation, no activity. And the pain is not only muscle, but this is also paresthesia, meaning not only is there no blood flow to the muscle, there's also less blood flow to the nerves supplying those muscles. So these are the cause now of this pain. This is called paresthesias. It's not pain in the sense of the word, but weird sensations, okay? Numbness, burning, like the pain you feel when you have a toothache, right? It's because you can't really compare a toothache with pain on your muscles, right? It's a different type of pain. The pain is usually in the distal part, because if you imagine here on the illustration, if the plaque is here, then and everything distal to that area will be deprived of blood flow. Does that make sense? So it's always at the end. So to the feet here, the toes will suffer the brunt, because if the plaque is here or here, regardless, they're all proximal. So the distal part always suffers the injury or the pain. And pain is relieved in a dependent position. Not like venous problem, wherein the pain is relieved when you elevate it. So this one, when you elevate the leg here, the pain actually gets worse. And stage 4, there's absolutely no blood flow. So the distal area goes black, tissues die, you could lose your leg. Now let's go to, so this is dependent ruber. So this is how the leg looks when you put them in a dependent position. It turns red, meaning blood flow is increased when you put it down. And when you put it up, it turns white, it turns pale, because it has less blood flow when you elevate it. As far as diagnosing, Let's get to that next. Let's do the ulcers first. This table is comparing the ulcers between arterial, venous, and diabetic ulcers. Now, this is arterial, so this is a blood flow problem. This is a venous ulcer, this is a venous return problem, meaning this one usually is caused by edema. This one, there's no edema here because the problem is not congestion. The problem here is blood flow. No blood flow. This one has blood flow, but has problems returning the blood back to the heart. So this is the problem here. Diabetic ulcers are more from the loss of sensation. There is damage to the nerves here. So the cause of the ulcer here is because they can't feel their legs or their feet or their toes. So this is usually because of neuropathy. So therefore, no sensation. Can you feel and can you protect those parts of the body that you have no feeling? No, you don't feel it. You don't care about it, right? So this is the location. So questions on the test will be the characteristics. How do they look? Where are they located? When do they form? The ulcer, how does the ulcer look? What is the color and appearance of the ulcer bed? So to help you remember these, just keep in mind what will happen if there's no blood flow to it. Of course, the ulcer bed will be pale. Usually here, because again, there's no problem with blood flow here. So that's why the ulcer bed looks pink. There is granulation tissue. This one, no granulation because there is no blood flow. Here, there is blood flow. Again, the problem here is a lack of venous return. There's actually congestion here. There's blood congestion here. This one has little or no blood flow. So that's how they look. See here, the foot looks pale. This one is darker because again, there's blood flow here, but then the ulcer bed, if on your textbook, it should look better. The ulcer bed here is red, so meaning there's blood flow there, but there's usually edema here. There's hardly any edema in arterial ulcers. And diabetes, again, this is due to lack of sensation. That's how they sustain these injuries. But if you compare this one to arterial and venous, diabetic ulcers are more likely resembling arterial. Okay, so they're more similar to arterial rather than venous. So here, in fact, because there's no blood flow, look at the hair now. There's no more hair. The skin looks taut, shiny. And here, the legs here look very ugly because of the edema. And because of the chronic edema, the chronic nature of the edema that forms here, there will be discoloration. Okay, it's like that leg is different, different color from the rest of the body. And these are usually chronic ulcers, so they take a long time to heal. Treatment. So the treatment here is usually, if they don't respond to wound care, they will need surgery. So that we need vascular surgery here to stent to put a stent in the artery, or maybe bypass if necessary. Here, there's no surgery needed except to debride the dead tissue. This will be painful. There is painful, these dressings here are compression dressings. They are very painful because we have to apply them with pressure. I mean, they're very tight, okay, and then they get tighter over the next few days. Una boot is applied wet, but when the boot dries up over the next 24 or 48 hours, it hardens and almost like a cast, but not as hard as a cast, but it does harden and the compression increases. All right, and then this one also is long-term foot care. just like arterial. So arterial and diabetic ulcers have similar treatments. This one is different. Diabetic and arterial do not involve um, compression dressings. This one needs almost 23 hours a day. They need compression 23 hours a day. So that's very painful. Diagnostic tests. So they do an ankle brachial index. So this is simply done by measuring the ankle blood pressure divided by the brachial blood pressure. If the answer is less than 0.9, then you have PAD. We don't do this at the bedside. This is done in radiology because we don't have the equipment here. Again, the doctor, the radiologist will divide the ankle blood pressure divided by the brachial systolic, okay, systolic blood pressure of the ankle, systolic brachial blood pressure. If the answer again is less than 0.9, that means you have PAD. The lesser the number, the worse the severity. Interventions now, then we'll be done. Non-pharmacologic first, we do exercise, only exercise to the point of pain. Okay, so of course, if there's already claudication, then we stop. Here's the description. So we instruct the patient to walk until the point of claudication, stop, rest, and then walk again, then repeat. Positioning also, again, it's better for the patient to put their leg in a dependent position because that relieves the pain. Raising their legs will only exacerbate the pain because you're not promoting circulation. We can do warm compresses, but make sure it's warm, not hot. Okay, remember they will have less sensation in these legs, so making them prone to injury, prone to burns. Avoid restrictive clothing. So Mr. Mitchell, if you're fond of spandex, so avoid those, okay?
You got it.
Okay, just making sure. Don't cross your legs. Again, promoting vasodilation, this would be heat. Make sure it's not too hot. Remember, again, the sensation is decreased here, so they are prone to burns. Stop smoking if you're smoking. Drugs, we have 2 drugs here, actually 3. Pentoxifylline and there's cilostazol here. So these 2 drugs are your main, pentoxifylline and cilostazol. They have 2 different actions. This one is inhibiting platelet aggregation. So similar to antithrombotic drugs like clopidogrel, aspirin. This one though is reserved for if the patient has disabling claudication, meaning the patient is now unable to walk because of the leg pain. They'll be put on cilostazol. The drug works by increasing the flexibility of the red blood cells. So this drug will allow the red blood cells to squeeze around the plaque buildup. Okay, so the red blood cells are disc shapes, right? I mean, they're flat and they're disc shaped. So this will make them more flexible. So that's what this drug does. They can also benefit from beta blockers because these have vasodilating effects. And if needed, stenting. So we have vascular surgeries. Here's the stents. Or if needed, they can also clean the artery. So they can, this is only done, of course, in large arteries. I mean, you can't clean tiny vessels. Or if needed, then you do bypass surgery. So here is the bypass surgery. The question, of course, is on pre and post-op. Remember that we are doing the surgery on a vessel here, on a large vessel. So there's a lot of things that could go wrong here. Bleeding is number one. Another is there could be a clot that will form. Just because you put a stent there doesn't mean the stent can't clot. The stent can have a clot also and can be obstructed. So your number one post-op job is to check for CMS. CMS stands for circulation, motion, and sensation. So give me assessment. Okay, so this is an example of a bypass. They can bypass here, or they can also bypass from the femoral down to the popliteal. So we call that FemPop, femoral popliteal bypass. This one is what's this called? Aortoiliac or aortofemoral. So either here to here or here to here. Oh, here's another long bypass. Look at the length of this. So from the subclavian down to the femoral. That's a axillofemoral. That's a long graft. Either way, again, your number one concern here is circulation to the distal extremity, to this distal part. So you check again for circulation. Checking circulation, you of course check for temperature of the leg, color of the leg, you feel for pulses, you feel for sensation and movement of the peripheral or the distal parts, okay, distal to the vascular intervention part. Here's the complication I was mentioning. So this is graft occlusion, meaning the stent could be blocked again, and that's always an emergency. You'll talk about compartment syndrome next semester, so I won't discuss compartment syndrome because we don't have time. I'm not testing the chart. This is a redundant chart already. This one, though, we do chart 36-6. So you'll see this foot care chart again in diabetes next week. This is foot care. So that means our diabetes will be a little bit short now because we already finished foot care, because this is exactly the same foot care in chapter 64. So we protect the patient's feet from injury because again, there's less circulation here and less sensation as well. So we protect it from injury. We're not testing acute peripheral occlusion. So next week we will finish chapter 36 with DVTs, and then after DVTs we should be able to start diabetes and finish before 11 o'clock. So I'll skip these compartment syndrome here, 6Ps. I'll leave this for 201 next semester. Any questions?
Nope.
Alrighty, so do we have a test next week?
No.
No.